So let's talk about skilled nursing. It's the hottest, sexiest area of informatics. Right? So when you think about skilled nursing, you probably mostly think about senior care, but it's a lot more than that. We're talking about sometimes pediatric, medically fragile children. Young adults live in those settings. You often see people who are needing specialized services like vents, dialysis, post-surgical cases, people who especially need therapy, right? There's 16,700 of them as of February. 70% of people over 65 will need long-term care. That's a really big number. And 1.4 people were in nursing facilities in 2022, which is the last time we actually have the data for. All SNFs that submit MDS, the minimum data set, to CMS, use some form of software. There are still people on paper. Most have some kind of hybrid record where they're using paper for some stuff and some electronic. Many use electronic health records, though. So CMS aims to have most beneficiaries in Advantage programs by 2030, right? But let's talk about Medicare Advantage. It has more paperwork. It pays less. And with the staffing mandates that have just come out for SNFs, SNFs are gonna have to decrease census to make those mandates work. And that's gonna decrease revenue, right? Some operators are probably gonna have to close wings, and some have already closed because they have staffing challenges right now, long before the mandate goes into effect. So let's talk about the triple aim. Never mind the quintuple aim, okay, right? We're still trying to get to the quadruple aim in long-term care. So SNFs understand the triple aim. It's just hard sometimes to help them understand where they fit into it, right? But when you're adding that fourth arm, improve the life of healthcare workers, in the current worker climate, that's really where you're gonna get your benefit, right? Like, it's so hard. You're struggling with staffing. Now they have to have certain staffing. But if they improve the lives of those workers and those residents, then they'll get there. So let's talk a little bit about another really sexy topic, value-based care and skilled nursing. So healthcare programs that deliver and delivery are designed to focus on quality of care, provider performance, and patient experience. That's just basically value-based care. That's the intent of value-based care. But continuum is the operative word here. It's no longer okay to just consider like a single care setting and when you're thinking about these patients. You have to think about where they started and where they end. And Medicare Advantage promotion is one of CMS's primary drivers for this program. Like, they want value-based care because they want to promote Medicare Advantage programs, right? So Medicare Advantage is challenging the sustainability of the SNF healthcare model. Your payer gets about $13,000 under risk-based contracts, but what they pay back to the SNF may be even lower than that, right? Sometimes it pays back about 80 cents on the dollar, but sometimes the most they get is about 30 cents on the dollar of what it costs to actually take care of the resident. And then when you think about a Medicare Advantage patient, they're a beneficiary, but that relationship that they have is shifted from Medicare itself to that Advantage payer, right? So the administrative costs of any resulting dispute over whether or not something should be approved, they get authorization, for example, is also totally shifted away from CMS right there. So your quality mix is the total number of Medicare, managed Medicare, and private days divided by the total number of actual patient days, right? So Medicare Advantage patients are increasingly a part of the quality mix in SNFs. Sorry, I just need to make this a little bigger. So it lowers those margins in some of those already cash-strapped facilities. Increased cost of staffing is absolutely affecting SNFs. The resources to negotiate those rates and those denials, that's a key part of it. So all that takes money. Staff to be able to do that negotiation. Staff to be able to submit that request for reauthorization. Staff to be able to answer that denial, right? So traditional Medicare, they get about $600 a day. Under Medicare Advantage, it's about $468 a day. We're talking about a 40 to 70% shortfall, depending on what plan they're in and what the circumstances are. So facilities are struggling because with Medicare Advantage, there's definitely more delinquencies and more shortfalls. You typically need a good volume of Medicare to remain solvent as an operator. For one plan, we saw 89% of the requests being denied, right? So organizations are either having to eat that or go through a collections process, which puts that huge administrative burden on the SNF. If they're not covered by the Medicare Advantage plan or Medicare, then they default to Medicaid, which goes your state burden. Then it's going to come out of the state budget. So a VBP is a value-based plan. These are just three that I'm going to talk about briefly, but the one we really need to think about and focus on is what we call an ISNP, an institutionalized special needs plan. That targets people who live in assisted livings or nursing homes. That's really your primary, what you see in SNFs. And then you have your chronic special needs plan, which are more for chronic cases with chronic conditions. And then your dual special needs plan target those who are eligible for Medicare and Medicaid. So when I talk about value-based care, these are the types of plans that I'm talking about and the most common in skilled nursing, right? So let's talk about the benefits of that, right? So let's go back to the quadruple aim, right? While you're getting better outcomes, increased family satisfaction, you're also getting increased clinical satisfaction and reduced turnover, because staff satisfaction is what's challenging in an industry with less resources than acute care to attract and retain nurses, right? So how many people here have watched a medical TV show, right? Like ER, right? Whatever, right? Dr. McDreamy. I always love it when they have the NG tube hooked up to the vent. That's my that makes me laugh so hard. When I was in nursing school, ER was one of the #1 shows, and my classmates and I had a study group, and we used to get together on the night the ER was on. We'd do our study group, and then when it was over, we would watch ER and howl and laugh at the screen. You would never do that. Why is he walking down the hall with dirty gloves, right? So anyway, so Hollywood makes Chicago Hope, right? But no one makes a show called Chicago Sniff, right? So SNFs don't get the love they deserve. They don't get the incentives that they should get to increase clinician satisfaction. So how do you incentivize quality, right? Change does require some effort and resourcing, and SNFs are just not incentivized to participate. They don't receive any of these financial incentives for participation. They've never been considered risk-bearing entities. The prospective payment systems always really worked well for SNFs. When you do retrospective payments, it doesn't really work when your margins are really tight like they are in a SNF, right? And tying revenue to value-based payments only makes sense if you're part of the incentives, and the incentives are immediate and they're the right size. But again, they're not incentivized. But if it's good for the patient, it helps us with survey outcomes, right? But until it's part of accreditation, or it's regulatory, or it's publicly reported, SNFs are just historically not interested in some of this stuff, right? But there are really good reasons for them to be involved. Relying on volume isn't a sustainable model, especially in light of the census challenges post-COVID, right? Value-based care plans, even with less SNF utilization, improves care quality and actually spills over into the other non-value-based patients that are in that facility. And then any additional eyes on those patients helps with resourcing and identifying changes in condition. That's really important for completing the MDS, the minimum data set that's submitted to CMS, because that's what drives reimbursement in a skilled nursing facility. So let's talk a little bit about data sharing in SNFs, right? So we aren't a sophisticated bunch as a whole when it comes to technology in skilled nursing. We were last to the party. Not all have informatics programs or nurses, and many rely on external vendors for IT support. It's very common. Many of the data sharing requirements were attached to the use of certified EHR technology, and the use of certified EHR is only mandated for meaningful use, and SNFs were excluded from those programs. right? So the use of certified EHR technology comes with additional regulatory burden on the SNFs. So they've always been reluctant to participate voluntarily, and they were sort of dragged into the value-based care world by their technology vendors. And then SNFs were excluded from ACOs originally because they weren't incentivized in a meaningful way to participate in programs that weren't mandated.